The Pearl Project. Obviously a name chosen for relationship to Pacific communities. But Pearl is an acronym, and thank goodness we have it because it stands for the Pathway to the Elimination of Antibiotic Resistance, TB and Latent TB and Leprosy in the Pacific. So this, a little bit drier than our last topic, but let me tell you a little bit about it. So this project is based in Kiribati. Kiribati is a group of islands, some 32 atolls, that is situated about halfway between Australia and Hawaii. It sits on either side of the equator, and it's also on either side of the date line. It has, as you can see from the circled area there, it occupies an area that is largely ocean. And as people from the Pacific would know, people see the ocean as their connection, not their separation from others. Only 20 of these islands are inhabited, and there are 133,000 people spread across these small islands. Kiribati is remote, as you can see, and it's also recognised by the UN as a least developed country due to its economic fragility, its isolation geographically, and its high vulnerability to climate change. So it is, and the people understand that many of its islands are sinking. So within this paradigm, other battles that the community face are health generally, but in particular diseases which we here often live under the belief in Australia that these two old diseases, both TB and leprosy, have been eradicated, but that's not true. And the reason we're working in Kiribati, as you can see from these graphs, is that Kiribati has some of the, well, it has both the highest rates of TB and leprosy in the world. So higher than, and the rates that we are finding will have actually contributed to what we're seeing on the graphs here. So in the activities that we're doing, we're actually finding more TB than we thought was there in what we already knew were high burden countries. So the Pearl study is a population-wide active case finding and prevention study for TB and leprosy elimination in Kiribati. It's got several aims. Firstly, to evaluate the effect of community-wide active TB case finding, and by that we mean, as it says, going into the communities and looking and testing and screening to see if anyone in the community has TB, rather than passively waiting at a medical facility, waiting for sick people to arrive. So we're going into the community, and we're also, with TB, both TB and leprosy, these are both infectious diseases that have long periods of dormancy in the body. For example, leprosy can exist in the body for 30 years, showing no signs of illness and not being able to be passed to another individual. But when a person who has inhaled or has been previously infected with leprosy becomes weaker in their immune system and frail for a significant period of time, then these diseases can develop. And it's likewise with TB. Often TB, you can be infected as a child, show no signs, have no disease. 90% of people who inhale TB will never develop illness, but if you're vulnerable for long enough and your immune system is no longer able to keep this dormant disease dormant, then TB also will activate. And both diseases have capacity to cause disability and death. So we go looking. We're also looking for leprosy cases, and we're also looking to optimise care and treatment for all people with TB through enhanced healthcare worker training in the South Pacific. So you can see we've got Pearl and we've got Pearl Plus. We started with funding in 2019 from the MRFF, and at that stage we were focused on TB infection and leprosy, and setting up a education network for TB nurses and community health workers who form the largest component of the TB programs, and they generally look after leprosy patients in their communities as well. So setting up a network across the Pacific, connecting these groups that work in isolation, developing their skills, giving them support, and building their confidence and skills in the work that they're doing. We then COVID presented many challenges to us, and we didn't really get underway until late 22, early 23. A lot of funding had disappeared in that time, setting up and supporting a range of activities that were COVID related. We then had additional funding from Department of Foreign Affairs and Trade, and became what is known as Pearl Plus. It linked us with a few other projects in the region, some climatic work that's going on in Fiji, as well as some work going on in Vietnam and Cambodia, also in TB. But with this, we were asked to also screen our communities, not just for TB and leprosy, but also for hepatitis B and scabies. And in addition, to do some additional work in surveying the National Immunisation Program to look at their coverage and effectiveness of the vaccine they were providing for TB, leprosy, and hepatitis B. And also to look at issues around gender equity and social inclusion. Mainly looking to see if the way we were implementing the project respected these concepts, and also to do a cost evaluation. We know that this is very labour-intensive activity, and we're looking to see if we can provide a cost evaluation, of course, to see if we can see a cost benefit there to inform future work in the area. So on the right is a map of one of the islands of Kiribati. It's known as Tarawa. There is North and South Tarawa. I mentioned that there are 133,000 people living in across the 20 inhabited islands of Kiribati, but in fact half of those people, around 63,000, live on this highlighted area of South Tarawa. So it is said to be more densely populated than Hong Kong, and this element of the community also makes it highly vulnerable to the transmission of these infectious diseases. But the reason we're focusing on this area is it's seen as the perpetuator of infection for the whole of the country, because as it's sort of the capital, if you like, and the CBD of the country, people from all islands come to South Tarawa, and then if they may be infected there, and then go back to their islands. So we see that we have a better chance of breaking the cycle by focusing on this part of the island. So, and I should say that I am an implementer as a nurse, more so than a researcher. But this slide describes our study design, and simply put, it's a test and treat approach. We start off by building community or stakeholder engagement. So the project is funded, whilst it's funded by DFAT, it's jointly implemented by the Kiribati government and the University of Sydney study team. And the group employ local people from Kiribati, nurses, doctors, data officers, laboratory workers to work on the project activities. In the community mobilisation, Pacific communities are really well organised and are very good at mobilising their communities with local activities. And so there's a series of community meetings. Of course, we meet with the community leaders, both their council, their government council, church leaders, and before we begin any work in each village as we progress down the islands of South Tarawa.
Well,
We then
a
have
couple more minutes, Kerrie. 2 more minutes.
Yep, no worries. I'll keep going. So, yep, I might move on, but we then go house to household and enumerate, and then offer screening. And for those that accept, we create appointments, and we then turn up at their houses on those given times to do the screening. Those who are found to be have suspicious for disease, we refer on to the national programs. Those that we can see from testing are infected with disease, we actually treat for 3 months with preventative treatment to reduce future risk of disease. This approach does need to be repeated a number of times to eliminate the disease, but that is that's the approach that's been shown in the evidence to date to make a difference. So we do some geospatial household mapping. We do 2 visits to implement the screening, to get the results and assess the outcomes. We deliver the preventive treatment for TB and leprosy beginning on that 2nd visit. And we're collecting the data on iPads and linking them back up to a REDCap database based here in Sydney at the uni. So this is the workforce, just an overview. We've got around 37 people now employed, recruiting a few currently. But we've been working with the team, and they're achieving screening 500 people roughly a week to move through the communities. This just shows that as of February, we've offered to date about 47%, almost half of the target population of South Tarawa have been offered, and we've completed screening on approximately 35% of those. Those villages highlighted in red are the villages we've completed screening in February, and the data relates to those. But you can see these circled areas where we've in Antibuka and Banriaba. We've also now completed in May, and we're currently working in Ambo. So we're about halfway along the island, but we are around 60% of the targeted area completed to date. This is just a summary. We probably haven't got time to go into detail, but this slide just shows you roughly what we've achieved to date. So in February, we'd registered approximately 22,000 people. We're now up to about 27,000. It demonstrates the high rates of those who screened positive, so signs suggestive of TB and leprosy, and then went on to be confirmed positive by the local programs and treatment initiated within their programs. We're showing where we have down here TST being positive, which tells us that the amount of infection. So that's telling us that roughly 1 in 5 people are infected with tuberculosis. They can't spread it to anyone. There's a 90% chance that they'll never get sick, but it's a potential. And you can see we've offered around 91% of people have received some form of treatment, be that only prevention for leprosy or prevention for TB. This again shows just some of the screening outcomes. And I guess what we've found, and it may not be surprising, that whilst rates of disease seem to be fairly equally spread between the genders in those who present to health facilities, we find here that when we go looking in the homes, we actually find that there are higher rates of disease in men, those particularly of working age and older. And this may well relate to coming forward and for a whole other range of reasons that are yet to be explored. This slide just shows us that conversely, whilst as opposed to those where we see higher rates of actual disease in males, this shows the rates of infection. So this is the stage of dormancy before disease. So we can see that roughly similar rates of males and females are infected, and yet it is more men that we are finding with disease. So this is an area that we'd further like to explore in the future. This is our treatment showing our treatment success. So there are people who are eligible, there are people who start treatment, and there are people who after 4 months have completed treatment. So that's about 67%. And whilst that might seem as though there's still quite a considerable gap between those who complete preventive treatment for tuberculosis, what we do know that on compared globally, that these are very good outcomes. It's very difficult to navigate and support people and motivate people to finish 4 months, 3 months worth of antibiotics. Challenges, I think these are challenges would not be surprising to you. It's features of working in remote locations. So we're talking about the logistics of transportation, petrol. Sometimes the country has no petrol, vehicle breakdown and repairs, very difficult to get parts, power outages, internet connectivity. Initially, we had no internet. It's actually our medical lead who set up internet with Starlink. It's made a tremendous difference to the project. Data capture, of course, the more people we're registering, the more records we have, the slower it slows down our data capture. Medication shortages, we can have shortages and stop outs for months while we're waiting for supplies to arrive. And, this is a consequence of being in the middle of this specific, where supply chains are less reliable than what we are used to experiencing. Telephone, we function there's usually about 400 to 500 patients at any one time taking preventive medication, and the nurses are ringing these patients on a weekly basis, and these are all done on $2 recharge cards because of the infrastructure within the island. So you can see how manually demanding these are for the workers, and I have to say, it couldn't be achieved without their dedication. They are firmly focused on improving the health of their people and communities. So, and they'll work after hours, on weekends, whatever, to meet the demands for that week. Staff turnover and absenteeism, they often reflect is an issue for them. So it creates problems for, meeting the targets, of course, which is all on a research time-bound time frame. And of course, whilst people will often refer to Pacific time, the most important element about Pacific time is that people and family and culture comes first. And so and it is also interdependent that sometimes, well, they will always be the priority in whatever's happening on any point of the day. So that's also a challenge to funding and research activities such as that we are implementing. But again, it's their dedication to meeting targets that, irrespective of what needs to be done, they work very closely together to achieve the work that they're achieving. Community participation, of course, we have about a 10% refusal rate, which is not unusual. Transportation, blood and sputum specimens and patients and staff have to be transported from one end of the island to the other. It's only 35 kilometres, but it takes an hour both ways. So that's also challenging, and particularly when you've got power and petrol shortages. And working out, yeah. So I mean, there's some of our solutions too, but really, I think the most important thing to point out is that relationships are key. That building strong relationships with the local programs, the ministry, and the DFAT and the local communities really underpins any success that the project is having, and of course, I think it's the spirit of the Pacific which will take them to meet their final targets. So I'll leave it at that.